Endometrial carcinoma. In India, the incidence and ratio of body carcinoma to cervical carcinoma is 1:8 and 1:5. The highest prevalence of cancer cervix is due to infection with HPV. The highest incidence is due to injudicious use. Etiology of endometrial carcinoma. The first one is estrogen, where there is persistent stimulation of endometrium with unopposed estrogen. Age. 75% are postmenopausal with a median age of 60. 10% with postmenopausal bleeding have endometrial cancer. Parity. It is common in married and unmarried. Nulliparity is associated by 30%. Cervix carcinoma is associated more with multiparity. Late menopause. The chance of carcinoma increases if menopause fails to occur beyond 52 years. Corpus cancer syndrome. This includes obesity, hypertension, and diabetes. Obesity, which leads to high level of free estradiol as the sex hormone binding globulin level is low. Unopposed estrogen stimulation. Then we have tamoxifen, which is used in the treatment of breast cancer. Longer duration usage due to weak estrogenic effect increases the risk of endometrial cancer. Other causes include family or personal history of colon or ovarian or breast cancer, fibroid in 30% cases, endometrial hyperplasia in 25% cases. Pathology of endometrial carcinoma. Under naked eye, the uterus may be smaller, normal, or even enlarged. Two varieties are found. The first one is localized. The usual site is on the fundus. It is either sessile or pedunculated. The myometrial involvement is late. The second type is diffuse. The spread here is through the endometrium. The myometrium is commonly invaded and it may invade to reach the serosal coat. Spread of endometrial carcinoma. Direct spread. It is confined to the stroma but eventually spreads in all the directions. It infiltrates the myometrium and spreads to the parametrium or into the peritoneal cavity. It spreads to the cervix in 15% cases. Spread through the lymphatics involves the pelvic, the para-aortic, the inguinal, and the femoral lymph nodes. The lymph node metastasis depends on the degree of tumor differentiation, myometrial invasion, tumor size, and the pathological stage of the disease. The fallopian tubes and ovaries are involved, either through direct or through lymphatic spread. The vagina is involved in 10 to 15% cases. Thirdly, it spreads through hematogenous route. The blood-bone spread occurs late. The common site of metastasis includes the lungs. Clinical features of endometrial carcinoma. Patient profile. The patient is usually nullipara. Postmenopausal. There is history of delayed menopause, obesity, diabetes mellitus, and hypertension. Symptoms include postmenopausal bleeding, which might either be continuous or irregular. At times, it may be excessive. In premenopausal, the bleeding may be irregular and excessive. Watery and offensive discharge due to pyometra is seen. Pain is usually uncommon. It may be colically due to uterine contractions in an attempt to expel the polypoidal growth. Few patients, that is less than 5%, remain asymptomatic. Signs of endometrial carcinoma. The patient presents with features as mentioned in the patient profile. There may be varying degrees of pallor. Pelvic examination. Under this, the first one is speculum examination. The cervix looks healthy. Blood or purulent discharge escapes out of the external os. Bimanual examination. The uterus is atrophic or normal or enlarged due to the spread of tumor, associated fibroid or pyometra. The uterus is mobile unless in late stages when it becomes fixed. Rectal examination corroborates bimanual findings. Regional lymph nodes and breasts are examined carefully. Diagnosis includes history and clinical examination. Endometrial biopsy in 90% cases it is more reliable. It is done using a Charmin cured or soft flexible plastic suction cannula. Then we have the pepanicular smear. It is positive only in 30% cases. The fourth one is ultrasound and color Doppler, which is TVS, where the endometrial thickness is more than or equal to 4 mm, low vascular resistance, and intrauterine fluid. The fifth one is hysteroscopy, which helps in direct visualization of the endometrium and to take target biopsy. The sixth one is fractional curettage. It detects the extent of growth. It is done under anesthesia with utmost gentleness to prevent perforation of the uterus. Steps under fractional curettage includes endocervical curettage. Note the length of uterocervical canal, dilation of the internal os, curettage of the fundus of uterus, and introducing a polyp forceps. Then we have CT scan, which is computed tomography, MRI, that is magnetic resonance imaging, which detects myometrial invasion, and PET scan, which is positron emission tomography. Treatment modalities for endometrial carcinoma include surgery, that is extrafacial hysterectomy, radiotherapy, combined therapy which includes surgery and radiation, and chemotherapy.